Assalamu alaikum. So, I am Dr. Abdul Sami Ansari, Cardiology Fellow at Tabba Heart Institute. Today, I am going to present an interesting case. So, he's a 25-year-old male smoker with no prior coronary artery disease. Presents with recurrent chest pain for last 1 month, which increased for last 12 hours. Pain was intermittent and usually remained for 5 minutes, which relieves on its own and was on mild in intensity. Rightly, he was stable on arrival in ER, and there was no positive finding on examination except he was having ongoing chest pain, which was mild intensity. This was the X-ray, which is slight prominent markings, bronchoalveolar markings. This was the ECG, which showed 0.25 mm ST depression in anterolateral with deep T wave inversions. So after looking at the ECG and as the patient was having recurrent chest pain, so coronary angiogram was planned. This was the coronary angiogram, which showed normal coronary arteries. So after the coronary angiogram was came to be normal, echo was planned. So the echo showed almost mild LV dysfunction. So there was a suspicion of some cystic mass at the LV apex. So the differentials were made that it could be a tumor or some cystic lesion. There was also mild pericardial effusion. So this was the report which showed mild pericardial effusion with LV apical cyst with query of clot versus LV tumor. So the differential diagnoses were made, which were pericarditis, myocardial abscess, cardiac cystic tumor, hydatid cyst, or some aortic disease. So next step was taken and cardiac CT was planned. So the CT showed similar findings with cystic lesions having multiple septas in the LV apex. It was of almost 27 to 44.7 mm. So now the cardiac MRI was planned. It again showed similar findings with cystic lesion in LV apex with multiple septas, and the differentials were made for hydatid cyst, organized chronic apical thrombus. So based on these findings, patient was discharged on albendazole, but soon patient after 24 hours got readmitted with complaint of chest pain, vomiting on and off. On arrival in ER, patient was tachycardic with borderline hemodynamics. Patient was reviewed by CTS team and primary cardiologist, but and her team was done, which as the patient was unstable, so the surgery was high risk. Emergent bedside echo was done. So now this echo showed large pericardial effusion with some thinned out apical cape, which showed suspicion of ruptured cyst. So this large pericardial effusion giving features of tamponade. So as patient was unstable, labs were done which showed deranged renal function test and liver function test, which was normal before that. So the patient was going into the multi-organ failure. So it was planned for urgent pericardiocentesis, and fluid was sent for DR, CS, ABCS, and cytology. 120 ml fluid was drained, which was serosanguinous in color, and sent for the above mentioned studies. Chest X-ray was congested and JVP was distended. So IV Lasix was started. Patient start to make urine output. Patient was planned to proceed for surgery when he become hemodynamically stable and renal function test starts improving. So repeat echo was done after the tape, which shows much improvement. Now the pericardial effusion is almost resolved, with mild effusion still present. Although the patient started making urine output, but the creatinine is still going up, and it becomes 6.35. Although the infective markers are now improving. So the tachycardia and hemodynamics also improved. So IV diuresis continued as per the hepatic venous Doppler findings for hepatic vein congestion. All the pericardial cultures were sent, and days after the subsequent days, pigtail catheter was removed as there was no more pericardial effusion in repeat echoes. So after the pericardial fluid analysis came out, it showed reddish color with exudative picture and TLC of 1500 with neutrophils of 87% and very high ADL level of 155. So as the picture was exudative with high ADL levels, the patient was started on modified ATT as the SGPT of patient is deranged and was planned to give first line ATT once the ALT improves. Albendazole also continued after discussion with ID teams and radiologists as the findings were much likely of a hydatid cyst. So on 6th day of ATT, patient now improved clinically, making good urine output, and now renal function tests also begin to improve. The echinococcus antibodies came, which was positive. So as now patient was stable, labs were showing improvement, so plan to keep on medical treatment and was discharged on modified ADT with steroid. So the diagnosis was made of cardiac hydatid cyst, TB myopericardium, tuberculoma with superimposed hydatid cyst. So this was the follow-up echo after 1 week of the discharge and almost 2 weeks after starting the ATT. Now this echo shows almost complete resolution of the cardiac hydatid cyst. So on follow-up visit, patient remained completely asymptomatic. Echo showed resolution of the cyst. So surgery was deferred and planned to keep on medical treatment. I found this case report which was published in 2019 of cardiac hydatid cysts. So it's a very rare case, which only 0.5 to 2% of incidence. Usually cardiac cyst occurs in any site of the LV, in any side of the heart, but usually on LV free wall, as it is highly perfused due to abundant coronary perfusion, which gives favorable environment for larval implantation and cyst development. It also can occur at any age, but mostly in young to middle age. So its presentation is variable and largely depend on the size and location. Patients can be asymptomatic or can have chest pain, palpitation, arrhythmias, heart block, or heart failure. Diagnosis depend on first line transthoracic, then CT and MRI, and enzyme-linked immunosorbent assay test for echinococcals are confirmatory. So take-home message is cardiac hydatid should be considered differential diagnosis, and differential should include TB, infected cyst, bacterial infection, or congenital cyst.